Good morning, I'm Alexis Del Cid, and today we bring you an encore presentation of one of our very favorite episodes of All Things Heart. Our team is working hard behind the scenes this summer to bring you more amazing stories when our live programming returns in September. However, if there's an urgent update from the health system, we will be here to let you know first. Until then, enjoy this encore presentation and make it a great day. A single mother of 6 is told her heart is failing. What doctors did that gave her her life back and gave her kids their mom back. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. Next time you're out running errands, look around you because you'll see crossbody bags are everywhere. Erica Owens fits right in with the crossbody bag, but the one she carries contains the device that keeps her alive. The minute you set foot in Erica Owens' Kansas City home, it is clear.
This is my aunt, my dad.
Family is everything.
They have been there from beginning to end.
And she has a big family.
That's my youngest daughter. This is Keanu, he's 5. This is Jeremiah. These are their cousins, best friend.
It might look like Erica's wearing a simple crossbody handbag, but look just a little closer, you'll see this bag is attached to her.
This is as far as it can go away from my body. This is my blood flow.
This bag is her lifeline.
I tell everybody it's like Iron Man. I mean, the batteries keep me alive.
For Erica, the trouble began in 2021 when she was pregnant with her youngest child, living in Garden City, Kansas. She says she felt short of breath the entire 9 months and thought it was the residual effects of catching COVID and then pneumonia just a few months before her pregnancy. But immediately after giving birth, she felt so terrible, the doctors did a series of tests and discovered the problem was Erica's heart.
And they realized that my valve was regurgitating.
Not only that, but her heart was enlarged.
I guess the normal heart is the size of your fist. My heart was double or triple the size of that. So my resting heart rate was around 200.
At only 31 years old, she was in heart failure.
So, sorry, I get a little emotional. But they told me that normally people my age, it didn't happen to people my age.
She says nothing the doctors did for her at the other hospital helped. In fact, she felt like she was plummeting. Finally, Erica was transferred to the University of Kansas Health System, where she met heart failure and transplant cardiologist Dr. Zubair Shah. And his first words to Erica?
He looked at me and he was like, I'm going to save you. And so he just said, I'm going to save you. He went to my mom and my sister, and he was like, don't worry about her, I'm going to save her.
Dr. Shaw and his team determined Erica needed a new heart. But more immediately, she needed an LVAD, a left ventricular assist device. It would keep her old heart pumping while waiting on the transplant list for a new one. Dr. Matt Danter would perform the surgery.
I just remember him coming in before my surgery just to check on me. And he just seen the joy in me, and he was like, I came to see if you were ready, but I don't even have to ask. And he's like, let's get this done.
She woke up a little sore, but shortly after, Erica says she was enjoying newfound health and energy she hadn't experienced in years.
I take minimum 10,000 steps a day. In the beginning, I couldn't take no more than, I couldn't go up 3 steps before I literally was 3 steps. And here I am 2 years later. It's just going to get better and better and better. I have amazing doctors.
An amazing care team that enabled Erica to build more memories with the people who matter most.
My support system is beyond amazing. I had a lot to survive for.
We are thrilled to have Erica Owens here with us in studio. How are you holding up?
I'm good.
Seeing your story.
It's emotional.
And we have your team here. We should call you Iron Woman. Can we call you that? That's what your kids call you, Iron Woman. We also have her thoracic surgeon, Dr. Matt Danter. Dr. Danter is the surgical director of cardiac transplant and mechanical circulatory support for the health system. I want to see your business card, what that looks like on a card. And we also have Erica's LVAD coordinator and nurse, Tess Rosbarski. And Tess, Erica talks about you and says you were her go-to. You got her, you got each other, she loved you. And we also have Erica's, she loves you, present tense, sorry. And we also have Erica's heart failure and transplantation cardiologist, Dr. Zubair Shah, who told her, I'm going to save you.
Yeah.
And he joins us virtually. Thank you all for making time to join us today. Erica, right out of the gate, you've had the LVAD for 2 years.
Yes.
You've got your bag, your trusty bag with you in your lap. How are you feeling today?
I feel great. Amazing. Like, full of energy. Just happy. Happy I'm still here.
You look amazing.
Thank you.
With 6 kids, I don't even know how you are able to wake up and function.
I mean,
in general.
It's a task. It definitely is. It's not easy, but it's doable.
They adore you. You can tell walking into Erica's house, family is everything. How long after getting your LVAD were you able to get back to your normal busy mom mode?
Well, I had a lot of support from family that actually stepped in and was there for the kids. I'll say about 6 months. 3 months in, I was like, this is not normal. I need my kids. I need to get up. My mom was like, you have to heal. Just take it easy. And she was like literally right there next to me. I'm in the bed. She's laying on the floor on the pallet. And I'm like, okay, I'm ready to get up. And, you know, maybe about 4 to 5 months in, I started like, I need my kids back. They started coming back one by one. And I gradually started getting up, moving around. And next thing you know, it was 6 and it was like home alone again. So I have my 6 kids back in the house. Is crazy. And I'm like, okay, back to normal. So about 6 months.
Speaking of support systems, thank God for support systems, because you brought 2. If we brought your whole support system, we wouldn't be able to fit in this studio.
No.
But we do have 2 very important people who are in the studio, in the control room watching. There's Mom and your sister, Monica. Mom's waving, bottom left, Monica there.
Yes.
Those are your gals.
Yeah, my sister, she jumps on the kids. She's like, I got the kids.
I love it.
She takes all of them.
It's wonderful.
Yeah, it is.
Dr. Shaw, Erica's valve was regurgitating, enlarged. What was the root cause of her heart problem?
So it's very difficult to tell what really happened, but I don't remember there any family history of similar heart failure. So I think it could be pregnancy related. We call it peripartum cardiomyopathy. That comes to the mind. We did genetic testing to make sure there's nothing familial, and I don't think we found any mutated gene. So right now, the working diagnosis was peripartum cardiomyopathy. Some females do develop heart failure with pregnancies.
Pregnancy-induced heart failure. You're the second patient we've had on this season that we've talked about having pregnancy-induced heart failure. Dr. Danter, Erica's in her early 30s.
Yeah.
That is so young for something like this to happen. How often do you find yourself putting an LVAD into a woman as young as Erica?
Well, not infrequently, sadly.
Not infrequently?
No, it's a kind of a complicated question to get into, but the landscape has somewhat changed over the last sort of 5 to 7 years. But in situations where you don't have an option and someone's not stable enough to get to, it's still the sort of route that we'd like to take. It's kind of interesting as things evolve and the pump is so durable and so effective now, there's a different conversation that goes on about when to transplant and when is the right time to do that from a mechanical circulatory support standpoint. But unfortunately, by the time you reach sort of an advanced heart failure center, the notion of what the options are kind of limited to medications, LVAD or transplant, and there's multiple factors that complicate that pathway. So it's not uncommon to have younger people require this degree of support, and it's great that we have a really good pump that works.
And speaking of, we have Tess here, Tess Rosbarski. Tess brought all the LVAD gear to show us, and then we have a comparison, a show and tell. Okay, Tess, what do you have in front of you? And explain to me how it differs between the other model, which is the older model.
Yeah, this is Erica's pump. This is the old model, the HeartMate 2, and she has a HeartMate 3.
Okay. Hold that up a little bit so we can see the close-up. So that's the HeartMate 3. So that's inside Erica's chest, attached to her heart right now.
And Dr. Danter can better explain exactly how he's surgical.
There we go. Hold it. Nobody move. Okay, we're going to keep it right there. All right.
Dr. Danter can probably better explain how it's surgically implanted, but this is the portion that is surgically implanted into her left ventricle.
Okay.
So,
And then,
the blood spins around continuously
and
here.
it comes out there.
Yep, shoots out here in a graft that goes to her aorta.
wild.
Yeah.
Erica, what's it like having us talk about you and dissect you? And
Well,
You've seen
I've seen it, but my memory's not too good on that end.
Yeah.
I've seen it, but I can hear it.
Yes, and we're going to get to that in a moment because we're going to let our viewers hear what it sounds like a little bit later, so stick with us for that. What's it like for you on an average day? You wake up, are you like truly like Iron Man? You get your battery pack and
Well, throughout the night, I'm like tossing and turning. I'm grabbing my bag, going to each side. I wake up and immediately, so there's a wall unit. The cord is 25 feet, I believe.
Okay.
So you can't go no further than 25 feet from where it's plugged in, and it's 100% power throughout the whole night instead of going off of batteries, which is 16 hours. So you wake up, you unscrew from the wall unit, then you change to batteries, which will last you 16 hours, and after that is time to take medication and
get you through.
Yeah, just.
And Tess brought more items to show us. So what are the other things?
So the
you
batteries she's talking about, you do require 2 of them in order to sustain power throughout the day. We say like 14 to 18, so average 16 hours you get off of 2 batteries.
Okay.
Yep, and they require these clips in order to connect these 2 cords, the white and the black cord too, and that's what provides power to her actual controller.
And are both those battery packs in your purse
They
at all
are.
times? Can I feel it just to see how heavy
Oh
it is?
yeah.
Does it feel clunky when you're walking
Well, in the
around?
beginning, it was a little extra as far as the weight.
A little extra, yeah. It's one of 2 batteries.
Yeah.
This
that's
is
a
also
lot.
in her bag too.
It's like you're basically if you had
So it's like I'm
a
lifting
hairdryer in your
a
purse.
5-pound weight all day. Yeah.
At least.
a couple hair dryers. In
Yeah. Hair dryers.
How long do you plan to be places? Like if you're on a road trip, how does that work?
So I don't travel.
Okay.
I don't. And if I do, no further than 6 hours. So that's my maximum. But I have a backup bag which holds 2 extra batteries. And so if I feel like I'm going to be out, I also put like another set of batteries. So I have 2 extra set of batteries. I never have to actually change them. I'm back home in time. But yeah, there's a backup battery that comes with an extra. Oh, we don't have it here. But
It'll have, these should be in there, and then she'll have an extra controller in there as well in an emergency case, which is rare, but.
How do you educate each patient before you send them home with all this important gear? It would be so intimidating, I would think, for a patient.
I can only imagine what I remember vividly teaching her and her mom, and it's a lot. We kind of start with the basics of making connections from wall power to battery power and understanding, how it fits into this little half moon piece. And one of the biggest things that you require is a caregiver, and in this case it was Erica's mom, and she her biggest task would be learning how to change like the driveline dressing, which is a sterile procedure. And
who was more nervous, Mom or Erica?
I would say Mom.
Erica, is that true?
yes.
Yeah.
Well, and she's
Mom, raise your hand in the control if that's true. If that's true.
She still is nervous.
Yeah, she's
It's almost 3 years later, and she's. Do I need to come? Yeah, definitely.
Of course.
Yeah.
Now, is it normal to you to wake up and just do it? Is it second nature?
Yeah. It's sometimes I have to think, did I already? Yeah, I did it. Yeah. So yeah, I did. I literally have to, and then I'm like, I changed my batteries, and then I have to pull them out just to look and see the power. Okay, I already changed my batteries. So it's just so routine now that it's everyday life.
What do you do when you need to shake a shower with it?
So there's something called Tegaderm that I actually use. I call it a big clear Band-Aid.
Okay.
It sticks to your skin. There's no way in, no way out. So I put it over my incision area. It covers everything down to the cord, which has the cord going down to where water can't get in. So I cover that, and then I also have a water bag. I change bags, and it's waterproof. Nothing gets in either.
So you figured it out.
Yeah.
Well, it's a testament to the education process, but also how diligent Erica and her mom are to have no problems with a drive line, no problems with anything for this long a period of time is quite a testament to how diligent they are.
Compliant patient.
Oh, very much so. Yeah.
You were saying during our interview that your kids are kind of in tune with the beeps and sounds that come from you.
You know, so if I'm watching a movie or something and my bag is like beep, low battery. I turn around, my kids are already right there.
That is so good.
And
so good.
And they're like, and my son's like, hurry. And my daughter's like, she has at least 15 minutes. She's okay. And then my 2-year-old, well, he's now 3. My 3-year-old, he grabs them and he puts them back in the charger. So, and then he be like, Mom, he comes down like, Mom, I did it. And so, you know, I always go and make sure, just to make sure. Never, not once have. At first he used to take them and you'll just hear it beep, beep, beep. I'm like, what are you doing? He's just putting them in different, and I'm like, you
can't. Like Transformers.
Yeah, so he's at a place now to where he's like, he knows how to perfectly put them, and he waits for the beep. And then he screams, he did it. So
I love that.
Yeah.
So good.
Yeah.
We have so many questions coming in from our audience already. If you have a question, send it to us right now on YouTube, Facebook, or a comment you can send in on the All Things Heart email as well. You'll find all the links right there on your screen. That's how you can communicate with us in real time. We'll be reading your questions and your comments. Dr. Danter, we showed all the outer parts of the LVAD, and now we want to show an animation of what's happening inside the body. Can you walk us through what we're looking at here and how it keeps her heart pumping?
Sure. So Tess already mentioned that this is the portion of the cannula that's inside the patient's heart.
The left ventricle.
Yeah, and there's a sewing cuff that we put on the apex that you can kind of see right underneath where the arrow ends. For the left ventricle portion of it. And then what's not shown on what we don't have on the model, but Tess also described, is screwed onto this is a outflow graft. And this is the difference between this pump and other pumps. Obviously, this is an axial flow pump, meaning it's a turbine like an Archimedes screw that spins. This is a magnetically levitated, so this houses magnets that lift an impeller and spins this around so that there's less blood contact. And this is very what they call hemocompatible, meaning it's not prone to clots or strokes or blood clots. And then this outflow graft goes up to the ascending aorta. And of course, driveline, we typically tunnel out, as we did with Erica, to the right upper quadrant in the abdomen. And basically, it spins at a fixed rate, and it generates outflow to assist the pump. It's a very aptly named device.
And then you have an older model to your right here on the set.
Yeah.
Now, what strikes me is that is huge.
Yes.
That used to be inside people when you first.
Correct.
Did you first start doing surgeries using that?
This was a revolutionary pump. We have a very interesting sort of selective memory about things. This pump right here, although it was huge, was orders of magnitude smaller than the other alternative at the time.
How big was the alternative?
The other looked about the size of a dinner plate. There were two of them. One was a XVE, which had a big sort of housing that was like this, and the other one was a HeartMate 1, which was this big. They all sat in the left upper quadrant. This here also similarly, this is the apical portion, goes inside the heart, and this is the outflow graft portion. But these would sit in the left upper quadrant. So if you ever had to actually take one of these out, you actually made an incision underneath the rib cage to get it out. But again, this was a revolutionary pump. I remember when I was in training, we would have all these people with paracorporeal devices or pushing around a big refrigerator. and our last guy would see all the HeartMate 2s come in and go home and come in and go home, and he was still stuck on his PVADs. But this was a revolutionary pump, and then as things incrementally improve, what you have is, this still had issues with significant stroke and thrombosis. And so you're moving through this. There's a pump in the intermediary stage that we don't really talk about anymore, called an HVAD. But then there's the HeartMate 3, which is, you can see it's functionally much smaller. It's designed to be an intracorporeal device, meaning the pump itself is all inside the patient. So was the HeartMate 2, but much bigger incisions. And this pump allows us to put the pump in using different techniques, and is so durable now that the most recent data on this pump that came out about a week ago is actually fantastic.
Oh, that's so great.
Yeah, the long term, we're talking about, they don't quite meet what the survival rates for transplant are, but it's getting to the point where it's in the same realm for discussion. So the big discussions that come up now is largely about timing of device compared to transplant. Because if you transplant someone at 20 years old, you're almost certainly going to need to transplant them again.
Oh, and you want to avoid.
And so what is the strategy that gives you the longest longest duration of life? Mm-hmm. So that's what we're talking about now. If you didn't have a pump that worked as well as this, then you can't have those conversations. So it's an exciting time in the space.
I want to bring Dr. Shaw into this conversation. Dr. Shaw, since the LVAD is doing all the work, Erica doesn't have a heartbeat or a pulse, right?
I mean, she does have, but it's very weak.
Very weak.
We can still do EKG and find a pulse, but with our hands, if you want to check the pulse, you will not be able to.
Which must be weird.
Because your eye is doing all the work.
We have an example of what our viewers would hear if they were listening to Erica's chest with a stethoscope. Let's listen. It reminds me of when decades ago you would wait outside a club to get into the club, and you'd hear the beat.
You can hear the music through the
if you're waiting in that line. That's wild. Do your kids ever put their ear to your chest and try to listen?
So when they're laying in the bed with me, you can actually hear it if you're laying on the pillows. They can hear it through the bed.
Wow.
Mm-hmm. Or if they're just laying on me, they can hear it if they're laying on my arms, my stomach, anywhere.
You are Iron Man. Iron Woman.
I am.
Dr. Shaw, what made Erica a good candidate for an LVAD?
To be honest with you, with our center, with the volume, we try to bail out all the sick patients. So candidacy for VAD is not as
firm, but generally we do it for people like Erica who come very sick, have well, although sometimes that's not the case, and there is not much time to transplant, and they are in shock, meaning heart is not pumping enough blood to keep rest of the organs alive. I know in Erica's case, I think she was sick for quite some time, and then she, what we call, suddenly decompensated to a point where organs would not like her heart being so weak. But coming back to your question, is generally people who come very weak, very late, don't have time to wait for transplant. But also other social issues is they need to be very good patients. As you saw, you need to maintain this pump, you need to maintain the drive line, you need to be very stable, have a very good routine. But most important, in my opinion, is also strong family support. Like Erica, you need people, especially initially after surgery, you need a lot of family support for a month or 2 months. We have frequent appointments to make sure her incision is healing, she's doing good, VAD is working well, we don't have to, recalibrate the speed, and they need to come almost every week for 1 or 2 months, and you need someone to drive them in. You need someone who does what we call dressing changes on the drive line site. So you need good family support, and she had exceptional support. And then also, the other factors would be how other organs are doing. But to be honest with you, we are not firm. We have offered VAD, and we have done LVADs in people who are 80 with good functional status. And with time, we take a lot of risk, and our guidelines have become more loose to help as many patients as we can.
How long can someone be on an LVAD? Is it indefinite? Is there a time limit where you can only be on an LVAD for this long? Dr. Shaw or Danter or Tess, which one of you wants
Zubair,
to?
do you want to? I mean, there's
Yeah,
the short answer is there's no endpoint. Theoretically, these pumps should continue to spin, and
great.
And there's no. We have people on HeartMate 2 support over. I mean, I think the oldest one is like 18 years or something.
Oh,
so it's like, yeah, the first pumps were put in, and around 2003, 2003, I think. So there's people on support an extended period of time, and that's why and that was on HeartMate 2. So the HeartMate 3 has been around for a shorter period of time, but the long-term and intermediate-term results are excellent. So there's no fixed time limit.
We have some questions coming in from our viewers, so I want to get to those because we have quite a few. Okay, here we go. Of course, my screen went away. Okay, Jeremy wants to know, are LVADs a first step prior to a transplant, or sometimes is it just how your heart needs to work now? Dr. Shaw.
I mean, it's not always the first step. There are a lot of things happening in the field. It's how much time do we have, how sick the patient is, and second thing, what are the chances patient will get transplant fast? If someone is really sick, like Erica came, we don't have enough time to wait on the list, because transplant can take time, and it also depends on a lot of factors. So to save the life, we will do LVAD first. But people who are relatively stable, their chances of getting transplant are good. If they are sick, then we can go with the transplant strategy first. But to summarize, it's not always the first step. We can straight go to transplant.
Marie has a question for Erica. Marie wants to know, what types of activities do you have to avoid? You mentioned travel.
Swimming, water. I avoid any type of water.
Okay.
For sure. Traveling, just to be safe, because my batteries have to be charging at all times, just in case I need backup.
What if you had to fly somewhere? What would that look like?
Well, I can't go through like the detectors, metal detectors or anything, so I don't think I even have the option.
You do. We can always write you a letter. Yeah.
Okay.
Oh.
Yeah.
So
that's
if she,
new.
I was going to tell you after. Yeah.
So if she needed to fly to see family somewhere, well, it seems like all your family is around you. But if there was one rogue family member that happened to not be in your room at any given time, she could fly to see them?
Yeah.
And just need a letter from one of you?
We have, it's our TSA letter that we give our patients, and you just have to show it to them before you get to, the
good.
Sounds like
detectors.
travelers in my future.
We have, I think so. I mean, we have had people too that one gentleman was touring around the whole country in an RV with I think it was his 2 girlfriends, wasn't it? Or something like that? Yeah.
Sounds right.
With 2 girlfriends?
I believe so.
Okay.
Yeah.
Sounds right.
So
There's
it's
someone traveling to Spain right now.
Yeah.
Wow.
So people travel.
Oh,
so
So what about the transplant list, though?
Yeah, we can talk. We can talk about that, but usually we have ways around that too. If there's something you really want to do for a period of time and you're very stable, we can work around that.
Yeah.
You just change status for the time that you're away.
Oh, okay.
Yeah.
Keep your phone charged.
Yeah. Oh, definitely.
Well, no, we try as we evolve through the program here, we're trying to make sure that we get people back to as normal a life as they can be. It's not going to be. You're right. You can't. It'd be a weird time to go scuba diving, right?
Oh, yes.
Travel to the mountains,
right.
not the Bahamas.
But realistically, we can work with what people's goals
whatever
are.
people want.
Yeah.
Jim has a question. Jim wants to know, what happens if something breaks on the weekend with it, or at night if there's a problem? Who do you call, Erica?
I have an emergency LVAD line.
Okay.
They actually, before you leave the hospital, they program all emergency numbers in your phone.
And so you feel like
I would probably just run to the hospital, but
yeah.
but yeah, I would also call the emergency line.
So you have your support system set up, kids on standby,
Oh, yeah.
emergency line.
And everybody knows how to get right to the emergency line in my phone. They know where it is. Everybody has the passcode, facial recognition, everything.
Oh, that's
My
perfect.
youngest kids have facial recognition because they don't know how to do the numbers. So, yeah, I have pictures on there so they could actually just go right to it.
You're
Yeah,
such a good mom.
I try.
Such a good mom. We could talk to this whole team for another 5 hours, but we have to wrap it up right now. So I'd love some final thoughts from our guests. And Tess, I want to start with you.
Yeah.
How did you become so passionate about LVADs, this specific field?
I'll try to keep it short. My first job as a new nurse, was working on the cardiothoracic surgery and progressive care unit here at KU. I worked there 4 years before I met Erica, and that's where I was introduced to this patient population. And I don't know, I just, you really get to know the patients. It's more than, I mean, they are constantly multitasking because of having the LVAD internally and externally, whether you realize it or not. But you really get to know them, and then I just feel like those were the patients when I was on the 4th floor that I really got to hear stories from and learn about, and then I was able to marvel in, again, how this becomes muscle memory to you. Whether you're a readmit patient who knows exactly what's going on with your VAD and you're completely functioning with it, or you are an index implant and you are still learning about it. I mean, just watching the education unfold is really cool to just see them retain it all and then still live their life after. And
one of them sitting right next to you.
I know. Oh, I know. And I know. Yeah.
Erica, that brings me to you and your final thoughts. You're so full of gratitude. Anytime you talk about Tess, Dr. Danter, Dr. Shaw, you would start crying when I first met you.
And here I am now, yes.
What do you want our viewers to know about this team?
I was a total stranger when I came, and it just seemed like they did everything. Like, they were in and out the room like this, like, we have to do this, we have to do this. I watched so many movies, I'm like, do they care about me really? But my doctors really showed me how much they cared about me, and just for them to be like, we're going to save you. And I was able to see that every day that I was at the hospital, and I just, coming from a mind state where I was like, I'm not going to make it, and then to actually survive.
And thrive.
Yes. And they cared.
It's beautiful.
They really cared. Other than them saying we care, they showed it.
They sure do.
They did.
Dr. Danter, you don't always get to see the successful people right next to you.
Yeah, it's really rewarding. It is. It's something weird that we're sometimes conditioned to remember, just the ones that don't go so great, because that happens too. But I mean, this is, to be honest, the surgery is a small part of it. The greatest, sort of reason for Erica's success is Tess and the team and her family to take care of that. But it's very rewarding for me. We don't actually, the way it's set up, we don't actually get to see our VAD and transplant patients in clinic. Actually, they go through the heart failure clinic, so we don't get to see them unless there's something going wrong typically. So this is, you see the odd patient in the hallway or the thing like that, but it's very rewarding. And I think that Tess and the rest of the VAD coordinators and the team should, and rightly so, get the lion's share of the credit for the success stories.
And Dr. Shaw, you're the guy that walked in and said, I'm going to save you. And then you talked to her sister and her mom, who are here today as well, saying, I'm going to save her. What's it like to have a patient like Erica and know that that's going to be their forever memory of you?
I mean, it's very rewarding, as Dr. Danter said. And the fortunate thing is we follow them in our office also after that is done. So knowing the impact you made, not only on the patient, I always say that it's on the whole family, is extremely rewarding. And as Dr. Danter said, sometimes things don't go well, but it's that satisfaction that we tried our best to offer everything. And then we have an amazing team, a team that's willing to offer everything and work hard to keep patients like Erica alive. So it's the patients and it's the team that makes us going. Mm-hmm. By the way, I didn't say I'm going to save your life. I said we as a team.
Correction.
I always say we are going to save your life.
There you go. Erica, thank you so much for sharing your journey and your family with us, and raising awareness about LVAD. And thank you to Dr. Danter, Dr. Shaw, Tess, for being here and helping us tell this journey.